All right, shifting gears just a bit. We're still in liver land, but now we're talking viral hepatitis, specifically the alphabet soup, A, B, C, D, and E. For this section, we're going to narrow our focus to A and E because they behave very differently from B and C, and they matter to us in the lab in different ways. Big picture takeaway before we dive in, A and E are acute enteric viruses. They do not cause chronic hepatitis, and they're much more about epidemiology and clinical context than fancy serologies or long-term fibrosis staging. So if B and C are the slow burn, long game liver villains, A and E are more like short, intense flare-ups. Messy, uncomfortable, and usually self-limited. Some worthless knowledge. The word hepatitis literally just means inflammation of the liver, which is deeply unhelpful unless you ask why and from what. So here we are. So let's group these together right away because HAV and HEV are best friends epidemiologically. HAV is hepatitis A, of course, and HEV is hepatitis E. Both are fecal oral transmitted and are acute infections, and both are self-limited in most patients. These viruses don't integrate into hepatocytes, they don't hang around forever, and they don't quietly scar the liver over decades. They show up, cause chaos, and usually leave. From a histotechnology standpoint, this is important because you're unlikely to see chronic architectural distortion like bridging fibrosis or cirrhosis from A or E alone. If you're looking at a biopsy and seeing chronic changes, odds are high you're not dealing with hepatitis A or hepatitis E as the primary cause. Humor note, these are the hepatitis viruses that show up uninvited, eat all your snacks, and then disappear before you can kick them out. Hepatitis A is probably the one you've heard about the most, usually associated with foodborne outbreaks in travel. Key features is that it's self-limiting with an incubation period of about 2 to 6 weeks. It's spread via the fecal-oral route. The virus is actually shed in stool before symptoms even show up, which is why outbreaks can get out of control quickly. Endemic in regions with poor sanitation, in developed countries it's commonly linked to raw or undercooked shellfish or infected food handlers. A fun stat, about 50% of people in the U.S. are seropositive by age 50, whether they remember being sick or not. Clinically, patients present with fatigue, loss of appetite, and jaundice. Most recover within 3 months with full resolution by 6 months. For us in histology, you might see lobular disarray, hepatocyte ballooning, and inflammatory infiltrates, but you should not see chronic scarring patterns. And yes, there is a vaccine, which is why hepatitis A is much less dramatic in countries with good vaccination coverage. Some worthless knowledge, oysters don't get hepatitis, but they are excellent viral delivery systems, which feels unfair given their vibe. Hepatitis E is less talked about, but honestly, it's sneakier and in some cases more dangerous. Like hepatitis A, it's fecal-oral transmitted. It's usually acute. It typically resolves in 2 to 4 weeks. But here's where hepatitis E gets interesting and concerning. It's zoonotic, meaning animals can carry it. Reservoirs include pigs, monkeys, cats, and dogs, which means undercooked meat, especially pork, can be a source. Clinically, HEV is usually mild, except in pregnant patients. And this is the big red flag. Mortality rates can reach up to 20% in pregnant women, particularly in the 3rd trimester. Histologically, hepatitis E doesn't look wildly different from other acute viral hepatides. So again, clinical history matters a lot. Without context, the slide alone won't tell you it's HEV. So when you hear hepatitis E, think acute, zoonotic, and disproportionately dangerous in pregnancy. Humor with a purpose, HEV is the reminder that sometimes the most low-key viruses come with the most unfair consequences. Okay, So welcome to the hepatitis viruses that do not just show up, cause a scene, and politely leave. Hepatitis B is a long game virus. It has the potential to stick around, remodel the liver, and completely change the histologic landscape over time. And then there's hepatitis D, which is honestly kind of the ultimate freeloader because it cannot infect someone unless hepatitis B is already present. It literally requires hepatitis B surface antigen to replicate. Think of hepatitis D as the viral equivalent of someone who says, I can't drive, but I will absolutely wreck your car. From a histotech perspective, these are the patients whose biopsies make you slow down at the scope. Some worthless knowledge. Hepatitis B is about 50 to 100 times more infectious than HIV. Viruses love efficiency. One of the most important things to understand about hepatitis B is that there is no single predictable outcome. Same virus, wildly different patient trajectories. Let's walk through them. Most adults will develop an acute infection and successfully clear the virus. Their immune system basically says, not today. But on the severe end, you can see acute hepatic failure with massive necrosis, meaning hepatocytes are dying faster than the liver can compensate. This is catastrophic. Now, the outcome we care deeply about in histology. Chronic hepatitis, sometimes progressing to cirrhosis. This is where you start seeing fibrous septa, architectural distortion, and regenerative nodules. Basically, the liver attempting renovation with no blueprint. And then there's the quiet category, asymptomatic carriers. They feel fine, labs may be mildly abnormal or even normal, but histologically, damage can still be happening. Never trust the liver based solely on vibes. A mini clinical pearl, risk of chronic infection is much higher in infants than adults, which is why vertical transmission prevention is such a huge public health focus. Unlike A and E, hepatitis B is transmitted through blood and body fluids, which automatically raises the stakes in healthcare environments. Major transmission routes are birth from infected mother to infant, sexual contact, needle sharing, blood exposure, and contaminated personal items like razors or toothbrushes, and also needle stick injuries. Yes, this is why we treat every specimen like it has secrets. For histotechnologists, this slide is less about fear and more about respect for standard precautions. Because remember, many infected individuals have zero symptoms. You cannot visually screen risk. Also important, hepatitis B is extremely efficient at transmission, so much more so than many viruses people tend to worry about more. Worthless knowledge? Before universal precautions became standard in the 1980s, occupational hepatitis B infection in healthcare workers was dramatically higher. Gloves are not just fashion accessories. Here's the stat that usually makes people sit up a little straighter. HBV can survive outside the body for up to 7 days and still remain infectious. 7 days. This is not a fragile virus. So when we talk about cleaning protocols, sharps handling, and specimen management, this is why. Another key point, people can spread hepatitis B without knowing they're infected. No symptoms, no warning signs, which again reinforces the golden rule of laboratory medicine. Don't guess. Assume exposure risk is always present and work accordingly. Not anxiously, just professionally. In microbiology terms, hepatitis B is basically the cockroach of viruses, incredibly hardy, and very difficult to eliminate. Now let's zoom in a little more on what actually separates acute from chronic hepatitis B, because this distinction matters tremendously when you're looking at liver tissue. Acute infection happens within about 6 months of exposure. Symptoms can range from I feel kind of crummy all the way to hospitalization, because the severity is largely determined by the host immune response, not just the virus itself. Here's something important. Many adults will clear the virus without treatment and develop natural immunity, which is great, gold star for the immune system. But acute infection can transition into chronic disease, and we don't always get to predict who that will be. Chronic infection is where things get serious. We're talking persistent inflammation, ongoing hepatocyte injury, fibrosis, cirrhosis, and increased risk for hepatocellular carcinoma. In other words, long-term structural remodeling of the liver. Now here is the stat I really want burned into your brain. The younger the patient, the higher the risk of chronic infection. About 90% of infected infants become chronic carriers. Meanwhile, roughly 95% of healthy adults recover. So age is not just a number here, it's a huge prognostic factor. Histotech Pearl: if you see advanced fibrosis in a relatively young patient, always consider infections acquired early in life. Some worthless knowledge: your immune system is basically overdramatic as an adult, which is actually helpful here. This flowchart looks busy, but the story is actually pretty logical. Let's narrate it like a timeline. Most patients start with acute infection. From there, many develop either subclinical disease or mild acute hepatitis and recover completely. The liver regenerates beautifully because it is one of the few organs that truly knows how to rebuild itself. Seriously, if organs had personalities, the liver would be the overachiever. Then there's the small but important group. So about 5 to 10% progress to chronic hepatitis. Now once someone is chronic, several pathways open. Some remain inactive carriers, some progress to cirrhosis, and some develop hepatocellular carcinoma. And unfortunately, some require transplant. Notice something critical here. Liver cancer can develop with or without cirrhosis in hepatitis B. That is somewhat unique and clinically very important. Histology connection: when chronic inflammation persists, the liver keeps trying to repair itself, laying down collagen, forming fibrous septa, and distorting lobules. Think of it like patching drywall repeatedly until the wall is no longer a wall, it's just patches. Now let's briefly demystify the antigen alphabet, because students tend to see HBsAg or HBcAg or HBeAg and immediately lose emotional stability. Stay with me, it's simpler than it looks. The surface antigen, which is HBsAg, this sits on the viral envelope. If it's present in serum, the virus is present, period. Core antigens are HBcAg and HBeAg. HBcAg lives inside the virus. You typically don't detect it circulating free, but the immune response to it is diagnostically useful. Now, HBeAg is the one clinicians pay close attention to because it signals high viral replication, high infectivity. Translation: the virus is actively making copies and spreading. Histotech tie-in: these antigens can accumulate in hepatocytes, and historically, hepatitis B has been associated with those classic ground glass hepatocytes. When you see that smooth, glassy cytoplasm, that's packed viral surface antigen. It's one of those slides where you pause and go, well, hello there, Hep B. Some worthless knowledge: ground glass hepatocytes have nothing to do with lung ground glass opacities. Pathology just loves recycling dramatic terminology. And now my favorite kind of slide, because this is a cancer-preventing vaccine. The hepatitis B vaccine uses recombinant HBsAg, meaning just the surface antigen, not the actual virus. So the immune system learns to recognize the viral uniform without ever meeting the criminal. Immunology at its finest. Why this matters so much? Preventing HBV doesn't just prevent hepatitis. It prevents cirrhosis. It prevents hepatocellular carcinoma. The hepatitis B vaccine is considered one of the first true anti-cancer vaccines ever developed. Let that sink in. From a healthcare perspective, and yes, histotechnologists included, vaccination is strongly recommended because of occupational exposure risk. Not dramatic, just smart. A fun fact: countries that implemented universal hepatitis B vaccination saw dramatic drops in childhood liver cancer rates. That is public health working exactly how it should. All right, now let's talk about how the body fights back. When the immune system encounters hepatitis B, it produces antibodies against the viral antigens, starting with the big one, anti-HBsAg, the antibody to the surface antigen. If you remember nothing else from this slide, remember this. Anti-HBs equals protection. It means the immune system recognizes the virus and can neutralize it. Now, this antibody can appear for two very different reasons. Number one, vaccination, and number two, recovery from natural infection. Both generate immunity. But, and this is where interpretation matters, anti-HBs alone usually points towards vaccination. We'll connect that dot more clearly on the next slides. Histotech tie-in, you won't see antibodies on an H&E obviously, but understanding the serology helps explain why a liver may look normal despite prior exposure. Vaccines basically give your immune system a most wanted poster before the criminal shows up. Now here's the antibody that separates the vaccinated from the previously infected. Anti-HBC, antibody to the core antigen. Key concept, you only get anti-HBC if the actual virus entered the body. The vaccine does not contain core antigen, only surface antigen. So if a patient has anti-HBs and anti-HBC, that tells us they had a real infection and developed natural immunity. Meanwhile, present HBs and not present anti-HBC, that screams vaccination. This is one of those elegant little diagnostic distinctions medicine loves. Clinical Pearl, anti-HBC can persist for life, meaning the immune system never forgets that encounter. Histology connection, patients with resolved infections may still have subtle residual fibrosis depending on disease severity, another reminder that the liver keeps receipts. Now let's bring back our friend, or more accurately, our warning sign, HBeAg. When HBeAg is present, it tells us the virus is actively replicating, the viral load is high, and the patient is highly infectious. So clinically, this is not a quiet infection, it's a busy one. Think of HBeAg as the virus waving a giant flag that says, I am making copies of myself at an aggressive pace. From a pathology standpoint, higher replication often correlates with more active inflammation, which over time drives fibrosis. More inflammation means more injury, which means more repair, which means more scar. The liver tries its best, but chronic injury always leaves fingerprints. Some worthless knowledge, viruses are basically biological overachievers, unfortunately. Now this slide represents something we love to see clinically, seroconversion. When a patient produces anti-HBe, it usually means viral replication is slowing down and infectivity is decreasing. In simple terms, HBeAg present, that means the virus is winning. If anti-HBe is present, that means the immune system is gaining ground. This often happens as an acute infection resolves or when chronic infection shifts into a less active phase. Now, important nuance. Lower infectivity does not automatically mean zero liver damage. Some patients can still progress, which is why long-term monitoring matters. Histotech Pearl, even when viral activity drops, previously deposited fibrosis does not magically disappear. Scar tissue is very committed to its life choices. If you like shortcuts, here's one. Surface antibody equals protection. Core antibody equals real infection happened. E antigen equals high infectivity. E antibody equals infectivity decreasing. Boom. Hep B serology. Dramatically less scary. All right, let's bring everything together and talk about how this actually shows up in the real world. When clinicians suspect hepatitis B, they draw blood and test the serum for two major categories. The first one is viral antigens. These tell us the virus is present. So HBsAg means recurrent infection and HBeAg is active replication and high infectivity. So antigens answer the question, is the virus here right now? The second one is antibodies. These tell us what the immune system has experienced. If we see anti-HBs, that means immunity. If we see anti-HBc, then there's a prior or ongoing real infection. If we see anti-HBe, that means it's decreasing viral activity. So antibodies answer What battle has the immune system already fought? Now, one very important concept: timing matters. Serologic markers rise and fall depending on stage of infection, recovery, vaccination, and chronicity, which is why interpreting Hep B labs is less about memorizing and more about pattern recognition. Histotech tie-in: we don't draw the blood, but these labs tell us what kind of liver we might be looking at before the biopsy even hits the processor. Some worthless knowledge: clinicians love patterns. Pathologists love patterns. Honestly, medicine is just professional pattern recognition. Let's interpret our first scenario. We have high HBsAg. What does that immediately tell us? The patient currently has hepatitis B. Full stop. Remember, surface antigen equals virus present. Now the next question becomes, is this acute or chronic, or is the virus actively replicating? This is where additional markers like HBeAg and anti-HBC help refine the picture. But by itself, HBsAg is a giant diagnostic billboard that says, virus detected. Clinical Pearl: if HBsAg persists beyond about 6 months, we start thinking chronic infection. Chronic carriers are the patients whose livers we watch carefully for fibrosis progression. Now let's flip the script. No surface antigen, but high surface antibody. So the virus is not present, but the immune system is ready. This means the patient is protected. But how protected? Two possibilities: successful vaccination or recovery from prior infection. So now we ask the logical next question: how do we tell the difference? And this is where the core antibody earns its paycheck. Always move one step deeper when interpreting labs. Never stop at the first answer. Here is the diagnostic mic drop. If someone recovered from a real hepatitis B infection, they will also have anti-HBC. Because remember, you only develop core antibodies if the actual virus entered your body. The vaccine does not contain core antigen, so the patterns look like this. Vaccinated, you will see anti-HBs and not anti-HBC. Naturally immune after infection, we will see anti-HBs and anti-HBC. Simple, elegant, clinically powerful. Histotech Pearl: patients with prior infection may still carry subtle architectural liver changes. Yet another reason clinical history matters when evaluating tissue. The immune system is basically a scrapbooker. It keeps memories forever. All right, let's walk through another pattern. If a patient has measurable HBeAg, what does that tell us? The virus is actively replicating and the patient is infectious. This is not a quiet phase. This is the virus in productivity mode. Think of HBeAg like the virus turning on all the lights in the factory. Now, what do we hope to see next? Anti-HBe. When that antibody shows up, it usually means replication is slowing and infectivity is dropping. We call this seroconversion, and clinically it's a reassuring shift. Small reality check: less replication does not erase prior liver injury. Scar tissue is not known for its flexibility. Patients transitioning towards anti-HBe often show decreased inflammatory activity on biopsy. Fewer angry portal tracts, less interface hepatitis. The liver finally gets a chance to exhale. Viruses don't breathe, but hepatocytes definitely appreciate the break. Now here's a scenario that is deceptively simple. No antigens, no antibodies, nothing across the board. At first glance, you might think, great, totally healthy. But what this actually means is the patient has never been exposed and has never been vaccinated, which makes them completely susceptible. Immunologically speaking, this person is showing up to a viral gunfight with absolutely no armor. This is why vaccination matters, especially in healthcare environments where exposure risk is real. Most institutions track employee hepatitis B titers for exactly this reason, because accidental Sharps injuries are not theoretical, they happen. Fun fact, before widespread vaccination, HBV was one of the most common occupational infections in healthcare workers. Public health wins don't always get enough credit. Now let me introduce you to one of the strangest viruses in medicine, hepatitis D, also known as the satellite virus. Why satellite? Because it literally cannot live its life without hepatitis B. No HBV, no HDV replication. It hijacks the HBV surface antigen to assemble itself. Honestly, it's the ultimate biological freeloader. Epidemiology: roughly 5% of individuals with hepatitis B are co-infected with hepatitis D. But here is the beautiful preventative takeaway. If you prevent Hep B, you prevent Hep D. One vaccine, two viruses blocked. Efficiency at its finest. So here's an analogy. HBV is the getaway car. HDV is the criminal that can't escape without it. Why do we care about hepatitis D? Because when hepatitis B and hepatitis D infect together, disease tends to be more severe. We see faster, higher risk of fulminant hepatitis, greater likelihood of cirrhosis. Basically, the liver goes from fighting one opponent to fighting a tag team, and the liver is resilient, but it is not invincible. Histology Pearl: co-infected livers often show more aggressive necroinflammatory activity, more hepatocyte dropout, more bridging necrosis. It is not subtle. Now, speaking of viruses that love chronic inflammation, let's shift gears to another major player in liver disease, hepatitis C. If Hep B is the structured, organized virus, Hep C is the stealthy one. Let's dig into Hep C because this virus behaves very differently from Hep B. The first big concept: hepatitis C is primarily bloodborne. Transmission requires direct blood-to-blood contact, which is why you'll often hear it described as parenteral spread or parenteral spread. So unlike Hep A, which loves questionable food decisions, Hep C requires a much more direct route. Major risk factors: the highest risk remains through IV drug use. Shared needles are essentially an express lane for viral transmission. But it doesn't stop there. We also see risk with birth from an infected mother, multiple sexual partners, less efficient than Hep B but still possible, needle stick injuries, and yes, healthcare workers should perk up a little here, and sharing personal items like razors or glucose monitors. Basically, if blood might be involved, even microscopically, transmission becomes possible. This is why standard precautions are not suggestions. They are lifestyle choices in the lab. Gloves are fashionable. Wear them year-round. Hepatitis C can live outside the body longer than many people realize, sometimes up to several weeks under the right conditions, which means dried blood is not automatically harmless. Not to make anyone paranoid, just appropriately respectful. An analogy: if Hep B is the loud virus that announces itself, Hep C is the quiet one that slips in through the side door. And as we're about to see, that stealth matters. Here is why hepatitis C really separates itself from many other viral infections. First, and this is huge, most people with acute Hep C don't know they have it. About 85% are asymptomatic. No dramatic illness, no obvious warning signs. The virus just quietly settles into the liver like an uninvited house guest who never leaves. Now, here is the statistic I want you to remember conceptually. 80 to 90% of infected individuals become chronic. That is an incredibly high number. Your immune system usually clears viruses. Hep C, not so easily. Why? Because this virus is a master of mutation. It forms what we call quasi-species. Basically tiny genetic variations that constantly change its surface proteins. Think of it like trying to hit a moving target that keeps changing outfits. The immune system struggles to keep up. Why do we care? Because chronic inflammation drives damage. Over time, about 20% progress to cirrhosis, and once cirrhosis is present, liver cancer risk climbs significantly. Not overnight. This is typically decades in the making, but it is a major pathway to hepatocellular carcinoma. Histology connection: Chronic hep C biopsies often show portal inflammation, interface hepatitis, and gradual fibrosis, until eventually architectural remodeling takes over. Remember, cirrhosis is not just scarring, it is the loss of normal liver organization. The hepatocyte neighborhood gets completely rezoned. In one encouraging update, unlike some chronic viral infections, highly effective treatments now exist. Modern antivirals can achieve cure rates above 95%, which is honestly one of the great success stories in infectious disease medicine. But, and this is important, damage that already occurred does not magically reverse overnight. Fibrosis is stubborn. Worthless knowledge, hepatitis C wasn't even identified until 1989. Before that, it was called non-A, non-B hepatitis, which sounds less like a diagnosis and more like scientists shrugging. So again, if hepatitis B is the organized virus, hepatitis C is the shapeshifter. All right, pause with me for a second. This table is not meant for memorization, it is meant for pattern recognition. If you walk away understanding the personality of each virus, you win. So let's zoom out and simplify what looks like a very busy chart. The first pattern, DNA versus RNA. Most hepatitis viruses are RNA viruses, except our oddball, hepatitis B, the only DNA virus in the group. There's always one that refuses to follow the rules. The second pattern, how they spread. Ask yourself one question. Is this virus food-related or blood-related? Fecal oral would be Hep A, Hep E. Think sanitation, contaminated water, travel exposure. These tend to cause acute illness, then leave. Bloodborne, Hep B, Hep C, and Hep D. These are the ones we worry about becoming chronic, because once a virus sticks around, inflammation sticks around, and fibrosis is never far behind. The third pattern, who goes chronic? Look at this progression. Hep A, never chronic. Hep E, typically not chronic. Now, compare that with Hep C, about 80% chronic. This is why Hep C drives so much long-term liver disease. Not because it causes the flashiest infection, but because it quietly stays. Stealth virus behavior. A quick clinical pearl, Hep B is vaccine preventable. Hep D requires Hep B, so it's a biological hitchhiker. Hep C has high chronicity, and Hep E is particularly dangerous in pregnancy. Medicine loves exceptions. Hep E is one of them. Histology tie-in that brings it home. Here is what I really want you thinking about as future histotechnologists. Different viruses, same downstream pathway. Chronic inflammation results in fibrosis, cirrhosis, and increased cancer risk. The liver has a limited number of ways to respond to injury. Etiology changes. Architecture damage looks familiar. Analogy, all roads lead to fibrosis. Some roads are just faster than others. So if you remember nothing else from this table, remember this question when you hear hepatitis. Is this likely acute or something that may remodel the liver over decades? That single thought process will take you very far in clinical reasoning. Some worthless knowledge. Hepatitis comes from the Greek hepar, meaning liver, and itis, meaning inflammation. Medicine is basically Greek plus bad handwriting. Now that we've covered infectious causes of liver injury, let's talk about a condition that is rapidly becoming one of the most common liver diseases, and no virus is required, which is fatty liver disease. So we spent a lot of time talking about infectious causes of the liver. Now we're going to pivot because the liver does not need a virus to get into trouble. In fact, fatty liver disease is rapidly becoming one of the most common liver conditions encountered in clinical practice. And what makes this particularly important? Much of it is preventable. Much of it is reversible if caught early. But like many liver diseases, patients often feel completely fine while damage is quietly progressing. The liver is incredibly polite. It compensates beautifully until it doesn't. Normal liver enzymes do not always equal a normal liver. Keep that in mind. Let's start with alcoholic liver disease because globally it remains one of the leading causes of liver-related morbidity and mortality. And here is something students often underestimate. This is not just about extreme alcohol use. It is about chronic exposure exceeding what hepatocytes can safely metabolize. Remember, the liver processes about 90% of consumed alcohol, which means hepatocytes are doing the biochemical heavy lifting every single time. Alcohol-related injury typically follows a predictable sequence. Steatosis, which is fat accumulation, then steatohepatitis, which is fat plus inflammation, and then fibrosis, which is scar deposition, and then cirrhosis, which is architectural collapse. Same pattern we saw with chronic viral hepatitis, just different trigger, same destination. The liver has a limited vocabulary when responding to injury. Think of fibrosis as the liver's version of duct tape, useful at first, but eventually interferes with function. Now let's zoom in on the earliest stage, the steatosis. This can occur even with moderate alcohol intake because alcohol metabolism shifts hepatocyte chemistry toward fat production and away from fat breakdown. So what happens inside the cell? Tiny lipid droplets begin forming. Those droplets merge, and soon the hepatocyte looks swollen and crowded. Eventually, the fat pushes the nucleus towards the edge, what we call macrovesicular steatosis. On gross appearance, the liver becomes enlarged, soft, yellow, and greasy. Not exactly the adjectives you want associated with an organ. Here's the encouraging part though. Steatosis is reversible. Remove the insult, meaning stop the alcohol, and hepatocytes can recover remarkably well. The liver is resilient when given the chance. Histotectinian, routine processing dissolves fat, leaving behind those classic empty vacuoles. So when you see clear spaces, don't assume artifact, think biology. And again, the liver is the only organ that can regenerate up to about 75% of its mass. Again, overachiever behavior. Now here's where things stop being forgiving. When fat accumulation is paired with inflammation, we call it steatohepatitis. Inflammation signals cellular distress. Hepatocytes begin ballooning, oxidative stress increases, and immune cells move in. And remember, chronic inflammation is the engine that drives fibrosis. What happens during fibrosis? Well, scar tissue begins forming around hepatocytes. Over time, it creates bands. Those bands disrupt blood flow and eventually isolate clusters of regenerating hepatocytes into nodules. At this point, the liver is no longer organized efficiently. Structure dictates function, and the structure is now compromised. Can fibrosis regress? Early on, yes, but continued alcohol exposure dramatically reduces that chance. By the time cirrhosis develops, we are managing damage, not reversing it. Clinical pearl: patients often feel fine during much of this progression, which is why liver disease can appear deceptively sudden. Analogy: fibrosis is like replacing flexible sponge tissue with stiff cardboard. The liver is resilient, but it keeps a very detailed memory of injury. Patients often, again, feel fine during much of this progression, which is why liver disease can appear deceptively sudden. All right, if there were ever a liver that looked like it was begging for a vacation, it's this one. Take a look at the size first. This liver is enlarged, what we call hepatomegaly. And notice that yellow-green coloration? That color is your big visual clue that fat has infiltrated the hepatocytes. Remember, fat is not supposed to be the dominant tenant inside liver cells. When triglycerides accumulate, the hepatocytes swell, almost like overfilled water balloons, and the entire organ becomes soft, greasy, and heavy. Fun histotech perspective here: if you were grossing this specimen, you would immediately notice how fragile it is. Fatty livers tear easily, and your blade will glide through it with almost suspicious ease, almost like cutting room temperature butter. Some worthless but memorable knowledge: a normal adult liver weighs about 1,400 to 1,500 grams. Severe fatty liver, it can exceed over 200 grams. That is a lot of metabolic regret. Now, important teaching point: this stage is often reversible. If the insult stops, hepatocytes are remarkably resilient little overachievers. But if alcohol exposure continues, the liver stops adapting and starts scarring, and that is when we enter far more dangerous territory. When tissue like this comes through the lab, remember, during routine processing, the lipid dissolves. So what you will see on H&E are those classic clear vacuoles, giving hepatocytes that Swiss cheese appearance. Students sometimes worry it looks like poor processing. It is not artifact, it is pathology. If lipid conformation is clinically important, this is when frozen sections with oil red O suddenly become very popular. Think of hepatocytes like carry-on luggage. A little stuffing, fine, but when you sit on the suitcase to zip it, something is about to rupture. It's the same energy here. Here is the hopeful part. Steatosis alone is still reversible. Remove the insult, alcohol, metabolic dysfunction, toxin exposure, and hepatocytes can recover remarkably well. But if inflammation enters the picture, if fibrosis begins, now we are sliding down a much steeper hill towards cirrhosis. And the liver is forgiving, but not endlessly forgiving. Now let's zoom in because histotechnologists live for this view. Those big empty circles you're seeing, that is fat. During routine processing, lipids dissolve out with the alcohols and clearing agents, leaving behind those classic clear vacuoles. So what you are actually seeing is the ghost of fat. Notice how the droplets push the nucleus off to the side. That is called macrovesicular steatosis, and it is the pattern most commonly associated with alcohol use. Analogy time. Imagine trying to sit comfortably in a beanbag chair while someone keeps pouring packing peanuts into it. Eventually, you get shoved to the edge. This is exactly what is happening to the nucleus. If someone ever hands you a liver biopsy and you see widespread macrovesicular steatosis, your brain should immediately start building a differential. Alcohol, obesity, diabetes, metabolic syndrome, or certain drugs. Fat is a clue, not a diagnosis. And here's something students often don't realize. Mild steatosis can be completely asymptomatic. Patients can feel totally fine. Meanwhile, the liver is quietly storing trouble. Classic liver behavior. Now we're watching the liver lose its patience. See the blue staining? That is fibrosis, collagen deposition, typically highlighted with a trichrome stain. When injury becomes chronic, hepatic stellate cells activate and begin laying down collagen like overzealous construction workers who were never told when to stop. Instead of flexible liver tissue, we get scaffolding. Fibrosis starts by wrapping around hepatocytes and sinusoids, disrupting blood flow and oxygen delivery. And once architecture is disrupted, function follows. Key histotech insight: fibrosis is not just a structural problem. It makes tissue firmer, harder to section, and sometimes tricky to embed well because you're dealing with uneven density. Gross rooms feel it, microtomes feel it, everyone feels it. Analogy: think of the liver like a sponge. When it's healthy, it's soft and compressible. When it's fibrotic, it's slowly turning into a kitchen scrub pad. Still functional, but definitely not ideal. A critical teaching moment here: steatosis is reversible. Fibrosis is much harder to reverse. Cirrhosis is largely permanent. This is why early detection matters. Let's talk about why this is happening, because the mechanism matters. First, dose matters. Around 80 grams of alcohol per day can produce reversible fatty change. Now for context, that is roughly 5 to 6 standard drinks, depending on your pour strength, and we all know pours are rarely honest. When intake climbs higher or persists for years, injury accelerates. And prolonged intake above 160 grams daily for a decade or more, well, that is a fast track towards severe liver damage. But here is something many people don't realize. Only about 10 to 15% of chronic alcohol users develop cirrhosis. So what gives? Genetics, metabolism differences, nutrition, and hormonal factors. Which leads us to the next point: gender susceptibility. Women develop alcohol-related liver injury at lower doses than men. Why? Primarily differences in alcohol dehydrogenase activity and body fat composition, meaning higher circulating alcohol levels for longer periods. Same exposure, more injury. From a histology standpoint, the progression tends to follow a predictable arc. Fat equals inflammation, which leads to fibrosis, which leads to cirrhosis. And once cirrhosis develops, we are no longer talking about adaptation. We are talking about survival. Now let's layer in something that makes medicine both fascinating and complicated: genetics. Because here's the truth: not everyone's liver responds to alcohol the same way. Some individuals develop cirrhosis faster, some tolerate years of exposure, and some physically cannot tolerate alcohol at all. That variability often comes down to enzyme function. You may remember the alcohol metabolism pathway. Alcohol, acetaldehyde, acetate. The enzyme aldehyde dehydrogenase, or ALDH, is responsible for clearing acetaldehyde, which, by the way, is extremely toxic. Now, certain populations carry a variant called ALDH2 deficiency. About 50% of individuals of East Asian descent carry this variant. If someone is homozygous for it, acetaldehyde builds up rapidly, producing flushing, nausea, tachycardia, and fatigue. In other words, their body is loudly saying, "Please stop doing that." Honestly, it is one of the few examples where genetics actively protects against alcoholism. Now, another important point: cirrhosis rates are higher in African Americans compared to Caucasians, even when controlling for some risk factors. Why? We don't fully understand yet. It's likely a combination of genetic susceptibility, metabolic differences, access to care, and comorbidities. Medicine loves humility because the liver still keeps some secrets. Clinical Pearl: risk is never just exposure. It is exposure plus biology. All right, let's pivot, because here is something students almost always find surprising. You do not need alcohol to develop fatty liver disease. Welcome to NAFLD, non-alcoholic fatty liver disease, now the most common metabolic liver disorder. And honestly, its rise parallels one major public health issue: obesity. NAFLD is strongly tied to metabolic syndrome, which is essentially a cluster of physiologic stressors: visceral adiposity, insulin resistance, hypertension, dyslipidemia. Think of metabolic syndrome as the body living in a constant state of biochemical traffic congestion. Too many nutrients, too much glucose, too much fat. The liver becomes the storage unit, whether it wants the job or not. And here's the kicker for your histology brains. Under the microscope, non-alcoholic fatty liver disease looks almost identical to alcoholic steatosis. Yep, you cannot reliably tell them apart histologically without clinical history, which is a beautiful reminder that pathology is never practiced in isolation. Slides tell a story, the patients provide the context. And here's what makes non-alcoholic fatty liver disease tricky. Many patients are completely asymptomatic. No pain, no warning lights, just quietly accumulating fat. Often it gets discovered incidentally when liver enzymes are mildly elevated. Quick lab refresher: ALT and AST leak into circulation when hepatocytes are injured. Think of them like intracellular secrets spilling out. Imaging, especially ultrasound, frequently shows that classic bright liver appearance. But remember, imaging suggests fat. Biopsy confirms severity. Now the good news: simple steatosis is often reversible, and unlike alcoholic liver disease, the treatment is not abstinence. It is addressing the underlying metabolic drivers: weight loss, improved insulin sensitivity, dietary changes, or exercise. Not glamorous, but wildly effective. Again, the liver is incredibly forgiving if we intervene early. Ignore it long enough, though, and non-alcoholic fatty liver disease can progress to NASH, or non-alcoholic steatohepatitis, fibrosis, and eventually cirrhosis. Same destination, just a different road. We've talked about inflammation, fat accumulation, fibrosis. Now we arrive at the complication that keeps hepatologists up at night: neoplasms. And yes, it is a tumor. Bonus points if you heard that in your best Arnold Schwarzenegger voice. Liver tumors fall into two big categories: primary, which is originating in the liver, and metastatic, spread from somewhere else. Fun fact that is absolutely testable in life: the liver is one of the most common sites for metastasis. Why? Because it filters blood coming from the GI tract via the portal circulation. Basically, if tumor cells enter the bloodstream from the colon, pancreas, or stomach, the liver is often their first stop. It is the unfortunate airport hub of oncology. Primary tumors, especially hepatocellular carcinoma, or HCC, are strongly associated with cirrhosis, chronic hepatitis B or C, non-alcoholic fatty liver disease. Notice the pattern: chronic injury, regeneration, mutation risk. The harder cells are forced to replicate, the greater the chance something goes sideways. We will dig deeper into specific tumors next, but for now, I want you to remember one big thing. Chronic liver damage dramatically increases cancer risk. The liver forgives until it doesn't. All right, now we're officially in the big deal liver pathology territory. Hepatocellular carcinoma, or HCC, is the most common primary malignant tumor of the liver in adults. And the key word here is primary. Unlike metastases, which are way more common overall, HCC actually starts in hepatocytes. From a histotech perspective, this tumor almost never shows up out of the blue. It loves a damaged liver. Think cirrhosis, any cause, chronic hepatitis B or C, long-standing alcohol use, or NAFLD, that's progressed to fibrosis. Basically, if the liver has been inflamed, scarred, and regenerating for years, that constant cell turnover sets the stage for malignant transformation. HCC cells often try to look like hepatocytes: a trabecular patterns, thickened plates, bile production, but they do it badly and without architectural respect. The liver is one of the few organs where chronic injury plus regeneration is basically an engraved invitation to cancer. Let's start with some good news for once. A hemangioma is the most common benign tumor of the liver, and is, in most cases, is basically a quiet roommate that nobody knows is there. These are vascular tumors made up of tangled, dilated blood vessels. Think of them as a localized traffic jam in the liver's vascular system. Lots of channels, slow flow, but generally very well behaved. Grossly, they are exactly what you'd expect from something filled with blood. Red to purple, soft and compressible, usually sitting right beneath the capsule. And because they're subcapsular, surgeons sometimes discover them incidentally during imaging or procedures done for completely unrelated reasons. Now, important histotech moment. If you ever see a suspected hemangioma on a fresh specimen, handle it gently. These lesions are basically blood-filled spaces, and aggressive manipulation can turn your bench into a crime scene really fast. Histologically, you'll see large vascular channels, flattened endothelial lining, minimal atypia, and no architectural chaos. Very polite tumor behavior. Fun analogy: if malignant tumors are reckless drivers, hemangiomas are the people going 5 miles under the speed limit in the right lane, slightly annoying but not dangerous. Clinically, most require no treatment unless they get very large and start causing symptoms, which is uncommon. When you hear benign liver tumor, your brain should immediately go to hemangioma first. Now let's talk about another benign tumor, but this one deserves just a little more respect than a hemangioma. A hepatic adenoma is a benign tumor composed of hepatocytes, but unlike hemangiomas, these can actually cause problems. First major association you should immediately lock into memory: oral contraceptives and anabolic steroids. Estrogen has a proliferative effect on hepatocytes, and long-term exposure can stimulate these tumors to develop. This is why hepatic adenomas classically show up in young women with a history of oral contraceptive use, although we increasingly see them in patients using anabolic steroids or with metabolic syndrome. Grossly, they are often well circumscribed, soft, yellow tan to reddish, and commonly subcapsular. Now here's the reason we don't completely ignore these. They can rupture. Because they are highly vascular, spontaneous hemorrhage is a real risk, and intra-abdominal bleeding is never anyone's idea of a good time. So while they are benign histologically, clinically they sometimes get resected depending on size and risk factors. Histology Pearl, you'll typically see plates of hepatocytes, but notice what's missing. No normal portal triads, no bile ducts, disorganized architecture. It's hepatocytes growing without their usual neighborhood structure, like a subdivision built with no roads. If a provider tells a patient with a hepatic adenoma to stop oral contraceptives and the lesion shrinks, that tumor just told you exactly why it showed up in the first place. Benign does not always mean harmless. Hepatic adenomas carry bleeding risk and clinical attention. Remember that. All right, shifting gears a bit. We're leaving the benign world behind and stepping into pediatric malignancy. Hepatoblastoma is the most common primary malignant liver tumor in early childhood, typically showing up before age 3. So when you see a liver tumor in a toddler, this is the one that should immediately pop into your diagnostic brain. Clinically, these kids often don't look very sick at first. Instead, what usually triggers the workup is something a parent notices during bath time or a diaper change: abdominal swelling or a palpable mass. Not exactly subtle. Now let's talk gross appearance, since that's what we're seeing here. This tumor is typically solitary, well circumscribed, soft to firm, and tan to yellow. Sometimes shows areas of hemorrhage or necrosis. It can get large, and I mean impressively large, because the pediatric abdomen has a surprising amount of real estate. Hepatoblastomas often try to recapitulate fetal liver tissue. Recapitulate fetal liver tissue. You'll commonly see primitive epithelial cells, fetal hepatocyte-like patterns, and sometimes embryonal components. Occasionally mesenchymal elements such as osteoid or cartilage, because tumors like to be overachievers. Another high-yield clinical pearl is AFP is usually elevated, so that's the alpha fetoprotein. So if labs show a sky-high AFP in a small child with a liver mass, everyone starts thinking hepatoblastoma pretty quickly. If hepatocellular carcinoma is the liver acting like a rebellious adult, hepatoblastoma is the liver reverting back to its fetal phase and making very poor life choices. Good news moment: compared to many malignancies, hepatoblastoma actually has a fairly favorable prognosis when caught early and treated appropriately. A key takeaway: age matters in pathology. When evaluating liver tumors, always anchor your differential to the patient's age, because the pediatric liver plays by very different rules than the adult liver. Now we are officially in big pathology territory. When we talk about primary malignant liver tumors in adults, hepatocellular carcinoma, HCC, is the heavyweight champion. And here is your first major clinical anchor. Most HCCs develops in a cirrhotic liver. If cirrhosis is present, your index of suspicion should automatically rise. Think of cirrhosis as the chronically injured fibrotic soil where malignant hepatocytes are more likely to grow. Common underlying causes you should mentally connect to HCC: chronic hepatitis B, chronic hepatitis C, alcohol liver disease, or non-alcoholic fatty liver disease, and also aflatoxin exposure. Basically, long-term inflammation plus regeneration plus DNA damage equals tumor risk. Now let's walk through the gross specimen, since that is our histotech love language. You'll notice the tumor is often pale yellow, which reflects fatty change, sometimes greenish due to bile production by tumor cells. Can be single or multiple nodules, typically softer than surrounding cirrhotic tissue. And one thing I always tell the students: if the liver looks lumpy and there's a dominant mass, don't trust it. That combination should immediately make you think HCC arising in cirrhosis. Microscopically, you may see hepatocytes that grow in thick trabeculae, lose normal sinusoidal architecture, show nuclear atypia, produce bile. And immunostains often enter the chat here. So HepPAR1, Arginase 1, or Glypican 3, helping confirm hepatocellular origin. AFP is frequently elevated, but not always, so normal AFP does not rule out HCC. If cirrhosis is the chaotic construction site, HCC is what happens when the building inspectors stop showing up. Many of these tumors are diagnosed via core needle biopsy, which means small tissue, artifact risk, and crush distortion. So your processing, embedding orientation, and microtomy technique matter a lot. So big takeaway, when you hear adult plus cirrhosis plus liver mass, HCC should be at the very top of your differential. And unfortunately, prognosis is often poor unless detected early, which is why surveillance imaging in cirrhotic patients is standard practice. Let's shift gears slightly, because not every primary liver cancer comes from hepatocytes. Meet cholangiocarcinoma, a malignant tumor arising from the biliary epithelium. Translation: this is bile duct cancer, not liver cell cancer. And this distinction matters, both diagnostically and histologically. Think of it this way: HCC equals hepatocytes gone rogue, cholangiocarcinoma equals ductal cells staging a takeover. Completely different cellular origin, completely different microscopic appearance. These tumors can develop intrahepatic within the liver, extrahepatic meaning involving larger bile ducts outside the liver. If you ever hear the term Klatskin tumor, that refers to a tumor at the hepatic duct bifurcation, a favorite pimp question in pathology circles. Let's take a look at this liver. You'll notice the tumor looks firm, pale, fibrotic, and poorly circumscribed. Unlike HCC, which is often softer, cholangiocarcinoma tends to feel almost scar-like because it produces a desmoplastic reaction. Histology translation: lots of collagen. So when you're cutting the tissue at the microtome, expect it to behave a little differently, sometimes tougher, sometimes resistant to sectioning. Not your delicate fatty liver. Microscopic expectations: instead of trabecular hepatocytes, we'll see malignant glands, duct-like structures, mucin production, and dense fibrostroma. Honestly, under the microscope, it often looks more like an adenocarcinoma from the GI tract than a liver tumor, which leads to an important diagnostic challenge. Sometimes the hardest question is this primary cholangiocarcinoma or metastatic adenocarcinoma? Immunostains usually step in to referee that fight. This is not typically a cirrhosis-driven tumor like HCC, so instead think chronic biliary irritation. So we'll see primary sclerosing cholangitis, liver flukes, big in the Southeast Asia, chronic inflammation, and choledochal cysts, basically angry bile ducts over time. Patients often present late because bile duct tumors don't scream early. So common presentation would be painless jaundice, and painless anything in oncology should always make your internal alarm bells ring. Because these tumors are fibrotic, ensure adequate fixation, expect firm tissue at grossing, sharp blades matter, and slow, steady sectioning helps prevent chatter. Fibrotic tumors love to humble even experienced microtomists. Big takeaway, when comparing the two major primary adult liver cancers, HCC has a cirrhosis background, softer mass, and hepatocyte origin. Cholangiocarcinoma is a bile duct origin, it's firm, gland-forming tumor, and is desmoplastic. Different tumors, different behavior, different morphology. And last clinical reality check, neither of these are as common as metastatic tumors to the liver. The liver is basically the body's biological airport hub. Eventually everything connects. All right, that's the end. Take a deep breath. We just covered a lot of pathology. If your brain feels a little full right now, that is completely appropriate. Mine would be too. But before you mentally clock out, let's zoom out for about 60 seconds and anchor the big picture, because liver pathology is one of those topics where everything connects. The liver only has so many ways to respond to injury, no matter the cause. Virus, alcohol, metabolic syndrome, toxins, tumors, whatever. The liver tends to follow a predictable sequence: injury, inflammation, fat accumulation, fibrosis, cirrhosis, and possible malignancy. Different triggers, the same biological playbook. Okay, this is why recognizing early morphology change matters so much, because once cirrhosis develops, the architectural roadmap is permanently altered, and histologically things get sporty. All right, talk to you later.